Respected Chairperson, dear friends, first of all, I extend my gratitude as well as thanks to the organizers as well as the Turkish Association of Psychopharmacology, especially Professor Miset, for giving us this honor as well as the opportunity to share with you. See, now you have listened about OCD, clearly shows that OCD is the most challenging and painful disease in psychiatry. All the other psychosis, the person is not suffering. Here the individual is suffering. So something should be done to them. OCD is characterized by recurrent, irrational, unwanted, uncontrollable, and seemingly bizarre impulses, thoughts, images, doubts that induce severe distress, or by repetitive behavioral or mental rituals performed to reduce this distress. The definition itself is very obsessive. Obsessional fears tend to be about issues related to uncertainty, about personal safety or the safety of others. Compulsions are deliberately performed to reduce this uncertainty. Its prevalence has been estimated to be 2 to 3% in general population and around 10% patients attending the psychiatric outpatient. In practice, the anxiety and mood symptoms of OCD respond well to pharmacological treatment, but the cognition and action doesn't show adequate response. So when the patient has got anxiety and depression, I think they get relief from the pharmacotherapy. Once there is an action, it's very, very difficult to manage. So it is a pervasive and prolonged suffering. Its course remains episodic and recurrent. So the question of how long to continue pharmacological management remains unanswered from different points of view. Since the prevalence of lifestyle-related physical illnesses are already rising in the community, the anti-obsessional drug-related side effects like anticholinergic, endocrine, and sexual effects can add to it and limits their usage. So the question of beyond drug, what is imminent? Hence, we need to practice of psychological interventions as one of the main mode of management in OCD. Combination of above said issues blended with the cultural factors of the region are tried in a day-to-day practice. So, I am not going into the technical words which you have read in the textbooks like expose response prevention or rational emotive therapy, CBT, all those things. Certain things with a blended of all those things, we have developed one which I wanted to share with you. The key words in the management of OCD are not to give importance. Make them to live with the thoughts rather than suffering from it. Usually the patient comes and asks us, somehow we remove the thought. The thought should not recur. That is what the demand. Even after removing the anxiety and depression, he comes and says that, no, still I have the thought. Thought cannot be removed. That is the first contract we develop with the patient. So he has to live with the thought. Don't expect us to remove the thought. The disease means suffering with the thought. Now he has to live with the thought. So we are elaborating the same in this presentation with a description of psychological models of OCD and therapies. Very important thing, first level we explain to them is satisfaction and enough. For example, one person goes and washes the hand. He is satisfied with his action, so he goes to the other activities. He goes and locks. He is satisfied about his own action, so he goes away from it. This particular person in the disease, he knows that he has locked. He knows that he has washed the hands, but he is not satisfied. He doesn't feel enough. This is the pathology which we are going to attack. So we would have to tell to them that you are washing the hand not to clean. You are not checking the lock to recheck that whether it is locked properly. Actually, what he is doing is, he is washing only to satisfy himself. For example, if I am not satisfied with somebody else's action, that is called paranoid. When I am not satisfied with my own action, that is called obsession. So now we would have to bring him the satisfaction, and he has to feel enough. That is how he developed the magical number 6 times, 11 times, 12 times, like that. The next process is, we tell them that every thought is necessary. No thought is unnecessary. See, even if an obscene thought, or a religious thought, or an absurd thought, we say that certain thoughts are very much necessary. But it has to come in the appropriate situation and appropriate environment. So the occurrence of this thought is inappropriate. So every thought is necessary, no thought is unnecessary. No thought could be erased. This is the next level we make them to understand. The particular thought should come in a relevant situation. It should not arise inappropriately. All thoughts are neutral and useful. Hence, there is no need to remove a particular thought. That is the third level. We have to convince them that all thoughts are necessary. I have to wash the hands. I have to lock the things properly. I need not erase that thought. Even in a sexual activity, the sexual thought is very much necessary. That should not occur in inappropriate situations. So, hence there is no need to remove a particular thought. This is the first level we would have to reach. Now we explained like this, how thoughts become powerful. Once thought is under my control, the blue is myself. When thought is under my control, I am normal. When I go into the thought and thought dominates me, I become under the control of the thought, I am abnormal. That is the disease. So, washing hand is a thought which is under my control. I would have to say enough, then it is normal. But washing the thought, I go underneath the thought and I am dominated and powered by the thought, I become abnormal. So, all thoughts are beneficial for self. But when I suffer because of the thought itself, then it is a disease. Another thing is, do I get pleasure out of the thought? Do I enjoy the thought? Do I rejoice with the thought? Many thoughts of like obscenity or the philosophical or the religious and other type of things. Do I get pleasure out of the thought? Do I enjoy the thought? Do I rejoice with the thought? If yes, then I am responsible for the thought, so I can feel guilty. If I am unpleasant because of the thought, if I suffer because of the thought, if I feel low because of the thought, why should I be held responsible for the thoughts and feel guilty? This is an rationally we discuss with him. You say that you are suffering because of the thought, but you own the responsibility of the thought and you suffer. He will consciously, a mentally healthy person, will he able to feel consciously, effortfully bring an unpleasant thought and suffer? So definitely the thought is not under his control. So why should you be held responsible for the thought and why should you feel guilty? So, will anyone willfully have an unpleasant thought? Will anyone suffer willfully? If I don't do the action or ritual, I will suffer. This is another thing they say. Why should I wash like this? Why should I go and check like this? Why should I go and rearrange like this? They say that if I don't do that, I feel anxious. I feel depressed. I feel suffering. If I don't do the action or ritual, I will suffer. If I don't do the ritual, I am not satisfied. If I don't do the ritual, I feel discomfort. This is the patient's versions. After doing the ritual, was he satisfied? After completing the ritual, was he relaxed? Was he feel comfortable? He says that I feel comfortable, but he feels much more suffering. Why I am like this? most of his time and energy, everything is taken away by this action. Actually, he says that I get relieved. Somehow this cycle he has learned and he was repeatedly doing it. So after the doing the ritual also you are not. For example, there are so many cultural rituals where you would have to repeat 1008 times in an Indian puja, where he has to count 1008 times and do that. He feels happy. I have gone round this temple for about 108 times. He feels happy. You count so many names, rhythms, I things, you feel happy. Even to count, you have so many materials in your hand. You feel happy. But by doing this, you are feeling satisfied. This type of rational explanation we bring them. No. After I do it also, I suffer. So then why should I do the ritual? Why can't I suffer without doing it? So the suffering is same and it remains whether you do it or you do not do it. So the few things like pathology, enough, satisfaction, he is not responsible for the thought, and even after doing it, the suffering is the same. This is the cognitive aspect we reintroduce in the theory. If I don't do it, there is only one suffering. Why can't I suffer without doing the ritual? He has to be prepared to suffer without doing the ritual, which is comparatively less suffering. So the disease disappears. This is how we explain why this thought becomes powerful. All thoughts are neutral. Give importance, it gains importance. Once gained importance, it draws importance. Once it becomes an important thought, automatically it becomes powerful. Once it becomes powerful, it becomes more and more important, finally more powerful. So I always think about whether the thought is going to come, whether the thought has come, thought should not come, how should I remove? Like that he keeps on brooding over it. It's a cycle. So the power comes from the individual. So when the thought becomes powerful, correspondingly the individual becomes powerless. Once the thought is powerful, I have to give importance. When I give importance to the thought, then the thought becomes important. Then I become unimportant. This is what in the political circle happens. Suddenly one fellow becomes important, they start giving importance, he becomes important, and you become unimportant. The same method, the thought process goes. So thought was under my control, I was normal. Now I come under the control of the thought, I suffer from obsessive disease. This you have learned by some ways and means. We don't go into that. So what is the solution for this? Learn not to give importance. That is the only thing. Don't try to remove the thought. Don't try to control the thought. Don't try to overcome the thought. Don't try to bring in another thought to remove this thought. Just you ignore the thought. Only one thing he has to decide it. You determine, take a decision that I should not give importance. Let the thought comes. The first level of anxiety disappears. Now, how thought loses importance? Once you don't give importance, you don't lose energy. Thought doesn't gain energy. So you consolidate energy. As you keep on not giving importance, you don't lose further energy. And when the thought doesn't get further energy, it loses its importance. This is the cognitive concept. So thought becomes less important and less powerful. Lesser important and lesser powerful. Slowly least important. Finally it becomes unimportant. So far such a powerful and potent thought now becomes an impotent thought. So far such a powerful and potent thought becomes an impotent thought. We have not removed the thought, and he has not removed the thought. He is not trying to remove the thought. Just like any other thought, it goes to the brim of the consciousness, and to the periphery, automatically it withers out. When you try to push it aside, or you try to remove, or try to stop, what it means? You have given importance already. Hence, already it has gained importance. So, repeatedly, you learn to fail, you learn to use, you master the art of losing and failing. That is what obsessive compulsive disorder. People asked to remove the thought or want to be erased. All thoughts are important and necessary. If some people say that I get that obscene thought, I ask them, do you want to remove all the sexual thoughts from you? Then how are you going to lead? So not necessary at all. All thoughts are important and necessary. So don't try to remove a thought. As long as the mind is there, thought will be there. So the aim is to remove the importance of thought, to alter the significance of thought. When a particular thought does not trouble me, when a particular thought does not trouble, when a particular thought does not produce anxiety, when a particular thought does not produce suffering, then there is no more disease. So we have to teach them, learn to live with a thought rather than suffer with a thought. Start living means no suffering. No suffering means no disease. With this thing, I spent more time on the how we do the practice. Now, because we are going to publish this particular study, we have about sample size 22, inclusion criteria, diagnosis of OCD, duration more than 6 years, age 20 to 40 years, IQ above average, already treated with psychopharmacological and other forms of treatment, then severity score more than 30, severe impairment. Exclusions are any comorbid psychiatric illness, substance abuse, psychotic symptoms, physical illnesses like diabetes and hypertension. Procedure, patients with a diagnosis of OCD as per DSM-4 criteria, informed consent was obtained, patients were put on clomipramine, SSRI in adequate doses, no antipsychotics, either it could be atypical or whatever it may be, no features of anxiety and depression while we take up for this session, 12 to 16 weeks of psychopharmacological treatment with considerable reduction in the score less than 20. The methodology and philosophy was explained, assigned for treatment schedule of 3 visits in the first week, then bi-weekly for 6 visits, then weekly for 3 visits, then fortnightly for 6 visits, then once a month for 2 visits. Then the patient was kept on regular follow-up for the next 1 year. Patients were able to improve their functions. Dosage and number of drugs are considerably reduced, like from 60 milligram of fluoxetine, he can be reduced to 20 milligram. From 250 milligram of clomipramine, he can be reduced to 50 milligram. He feels very comfortable, and quality of life was improved, and families were very happy when he is able to say that now I don't bother about the thought, because obsessive relapses frequently. So we prepare them very adequately. Thank you.
Çok ilginç sunum için çok teşekkür ediyoruz. Çok sağ olun. Ben hemen kendi katkımı yapayım son sunumla ilgili olarak. Yani bir kadim medeniyet olarak Hindistan düşünce geleneklerinin de çok çeşitlenmiş bir yer olarak obsesif kompulsif bozuklukta da modern psikiyatriyle türdeş ve ondan farklı bir takım söylemleri de içermesi bakımından çok etkilendim sunumdan. Yani bizde de kültürel perspektifle bir fıkrayla izah edelim. Bir Laz fıkrası vardır. Yani yer çekimini iyi ki buldular, yoksa uçuyor olacaktık gibi böyle bir çarpık anlayışa düşmüş. Hani yani biz obsesif kompulsif bozukluğu şimdi modern psikiyatri tanımladı diye var değil. Shakespeare'in Hamlet'inde de elini yıkayan kahramanı vardı, roman kahramanı. Muhtemelen diğer kültürlerde de benzer ritüelistik davranışları olanları var. Bizim toplumumuzda da günde 5 kez işte ibadet etmenin ne kadar obsesif kompulsif bozukluk, ne kadarı kültürle ilişkili kabul edeceğiz, ne kadar da bunların dışına çıkıp bir rahatsızlık, bir hastalık boyutuyla bir formülasyon yapabileceğiz. Size güzel bir numune olması bakımından çok etkilendim sunumdan. Çok teşekkür ediyorum. Şimdi bir 10 dakika kadar soru ve katkılarınıza zamanımız var. Salondan eğer sorular ve katkılar olursa onları alalım lütfen. Oğuz Hocam, buyurunuz.
Ben son konuşmacıya, Sayın Thirunavukarazu'ya soracağım. Bu modelin çok benzerini ben de kendi kliniğimde kullanıyorum. Onun için bir benzerini görmekten önce mutluluk duydum. Şimdi tabii bu daha ağırlıklı kognitif bir yaklaşım tekniği. Burada hiç exposure'la bunu imajinatif ya da hani doğrudan exposure'la destekliyor musunuz? Onun burada yeri ne olabilir exposure'ın? Yani davranışçı bir tekniği içine belli bir yerde ekliyor musunuz? Ya da başarıyı bekleyip ondan sonra mı ekliyorsunuz?
Yeah, it is actually, to start with, we were doing all those things right from those days, the thought stopping onwards to exposure and response prevention, behavior aversion, so many things we were trying. But all these things in the behavior model, other things, the maintenance or consistency of the improvement were questionable. So the concept has to be changed. So first this stuck to our mind, and one of my patients only suggested, can't we live with the thought without suffering? See, that is how I got the clue. Why should we remove the thought from him? There is no need to remove the thought. So those things are now, we are trying still, we have the psychology department who tries all those things. But this concept has made us to get a big relief of putting them on the regular ERP and other things. Because you get different type of thoughts. This year he gets one thought. After 2 years he gets another type of thought. So once the thought concept is introduced to him, I think the relapse rate has come down. But he has to be followed up. We are following it up for more than 5 to 6 years now. People are doing fairly well. With this, the behavior modification has been reduced. Actually, it is not actually you prevent the response of the individual. You prevent the importance cognitively given to the thought. Both are different. A physical response prevention is not there. A cognitive way of he is preventing the response. So definitely I think if we follow it up and then we present with, now we are thinking of, already we are doing with an RCT model with this, what will be the outcome? Then we would have to put it these things. Another important thing is, as you told, many people, we are all practicing so many native methods depending upon our culture and knowledge. But many things are not documented. That is another important thing. This has to be done.
Yeah, please, Zohar. Dr. Zohar.
Thank for the group for excellent presentation. Where you put the family, since many times or sometimes the family in a way might support the obsessive compulsive symptoms. So the patient is coming and seeing you, and you teach him whatever he should do, and you spend with him the 50 minutes, and then for the next 23 hours or 2 days or 3 days is with the family, and they are doing what you're doing. So what, how you consider or deal with this type of issue?
See, this is another important one. We are talking about emotional expressivity in the relapse of psychosis. I think the emotional expressivity in OCD relapse has to be studied. It's a very, very important role they play, the family. Some families, they foster this behavior so that the problem is solved. So they protect the patient. This is one. Another one is this thing. But in this model, what we do is we keep the important family decision-making person. See, in Indian culture, not necessarily the spouse is the important person. Sometimes whoever is important in the family, you choose the leader of the family, head of the family, who is responsible, who has got a very high influence in the decision-making process, or whom the person is very closely attached. We make them to sit with them, and continuously this process is explained. Before this person recognizes the importance of this concept, the family accompanying person understands. So he repeatedly does it at home. The accompanying person becomes the therapeutic person in the future. So automatically, why should we go and wait and see the doctor who says the same thing, rather than he can save money and time by telling the same thing, share the things. So family or the very important accompanying person is very, very important in this type of therapy. If we think that some families are fostering and contributing the relapse, then as we attend to the emotional expressivity, we do the family counseling and therapy for them.
Doktor Bahri Bey, buyurunuz.
Çok teşekkürler güzel sorumunuz için. Gerçekten kliniğimizde yaptığımız şeyleri sizden duymak bizim için çok hoş oldu. Biz de benzeri bir şekilde bu düşünceler aslında senin düşüncelerin değil, hastalığın düşünceleri. Dolayısıyla hastalığın düşünceleri olduğu için sen kendini niye suçluyorsun? Burada bir gereksizlik var, üzerinden hareket ediyor gerçekten hocamızın da söylemleri doğrultusunda. Tabii burada hastanın başka komorbiditelerin olması, bipolar bozukluk komorbiditesinin olması örneğin tedavide bizi zorlayan şeylerden bir tanesi veya IQ sorunlarının olması, işte yaygın gelişimsel bozukluğun söz konusu olması biraz zorlaştırıyor. Siz bu durumlarda ne yapacaksınız? Ne yapıyorsunuz? Onu soracağım ekstra. Bir ikincisi travmanın, çocukluk çağı travmalarının OKB'deki etkileri önemli tabii. Onlar da benzeri disfonksiyonel düşüncelere yol açabiliyorlar. Biz çok fazla nöroşirurji kullanmadık. Bunun sonuçlarını da bilmiyorum tabii ayrıca. Sadece zorlandığımız şeylerden bir tanesi, işte bunlar senin düşüncelerin değil, hastaların düşünceleri. Dolayısıyla bunları karşılık verme dediğimiz zaman hastadan bazen tepkisi geliyor. Ben o zaman bu kadar parayı size boşuna mı veriyorum bu söylem karşılığında gibi bir takım absürt yanıtlar da olabiliyor. Çok teşekkürler.
See, this is something like our sexual problems therapy. We have to group, once we think about all those things, pharmacotherapy is hallmark. There is no doubt at all. Without none of these patients are out of the drug. They are very small doses of drug. There is that. Another next point is we must look into for predisposing factors, precipitating factors, and reinforcing factors. There are 3 factors are there. Certain factors are reinforcing, certain factors are precipitating, certain factors are predisposing. In that you can group all those things and try to attend to that individually. Frank cases of OCD, really it is very good responding one. But my teacher used to say that each person has got right to have any number of diseases. He is very aversive the word called comorbidity. Do you say that if a person has got hypertension and diabetes, do you call it as comorbidity? Like that in psychiatry also, he can have any number of diseases. It is his birthright. How do you say that it is a comorbidity? If LUT is like that, then we would have to attend to them accordingly. Then you would have to talk about these things. One very important thing now, which runs in my mind, is this clozapine. Most of these psychotic people, after they improve very well with clozapine, they come out with obsessive features. That clearly shows that something going on biologically. And once you withdraw that clozapine, I think the symptoms reduction is there. I don't know what is the observation of the alien audience in that. Other things we would have to compartmentalize and attack differently. Whether it's a predisposing factor, you attack accordingly. Precipitating factor or reinforcing factor has to be attended separately.
Buyurunuz.
Thank you very much for your presentation, because this is the type of work that I do. I come from Auckland, New Zealand, and I have tried typical cognitive behavioral therapy model on several patients in the last 10 years, about at least a dozen patients. But just 2 observations. One, that is there a cultural difference in the way people respond to OCD? Because the 3 patients that nearly are in remission for last 3 years, 4 years now, were all people of Pacific Island nations. which includes Samoa, Tonga, and Cook Islands. Whereas none of the European patients that I have been treating have shown such a remarkable recovery. That's one observation. My thought on that was perhaps that the 3 patients who really responded very well had excellent family support at the same time. So whether it was the family support which helped them or whether it was the cultural difference that helped them. The other thing is that, as you mentioned, the reduction of medication. When I started the therapy on them, they were on the top dose of SSRIs, clomipramine, and everything had been tried. And within a period of 1 year to 1.5 years, actually one of them is without any medication for the last 4 years. And the other 2 are on very minimal doses. So if we are talking about the biological and neurotransmitters, then what happens? When we talk to them, what happens to the neurotransmitters? How do they respond just to the therapy? Is it that we are more psychopharmacologically driven by the, of course, the trillion-dollar pharmaceutical company funded researches? And there is very little about psychotherapy in the last 30 years. Not much research, and that's why I'm very happy that you are doing this and publishing this. Thank you.
Thank you for your nice comment. See, this is what I also feel. Many of us are doing many things which is developed by the individuals, but we are not putting it in black and white. That is the one thing. So the knowledge doesn't disseminate when it goes without use. Another one is this concept about this, how a person improves with, yes, non-pharmacological method, but doesn't mean that it is not biological. That we must always keep it in mind. So now my presidential address on this was concept of manas, that was mind. I say that mind is 100% biological. Mind can be influenced biologically within the body itself, or it can be influenced from psychologically from outside the body also. Whatever may be, it has to finally traverse through the biological system. Then only you can perceive and enjoy or reject all those things. This can be affected either by biological means, that is molecule, or by psychological means, that the interactive process. Both can be, definitely can be brought out. I don't want to go into the whole controversy of all those things. Drug creates immediate relief, but long-standing relief, I think this has to come. And most of the studies also shows that both biological and psychological produces a much better result. So even the psychological means, it traverses only into the mind which is situated within the body. So definitely, finally, everything takes a root of biology and alters the chemistry. This is what my humble opinion about that. Even though we call that psychological means, doesn't mean that it doesn't affect any structural change. It does. That is what even I used to tell my students, that when you prove that by cognitive behavior therapy, you reverse a structural difference in the brain. If you do a wrong psychotherapy, definitely you can produce a structural damage also. That is also. You take the post-traumatic stress disorders. It is happening something outside. It goes and changes your biochemistry. So everything finally passes through the biology only.
The way you explained around reducing the compulsive, Now you explained very nicely how if you stop the compulsive acts, you suffer with the thoughts, and then that becomes less important. What I want to know is, in obsessive thoughts, they're intrusive obsessive thoughts that patient have no control over. Now, I had a patient who had obsessive thoughts about dying. He worries constantly about his family dying. I treated him with fluoxetine 60 milligrams. That reduced the frequency and the intensity of the thoughts. But time to time, he still have recurring intrusive, obsessive thoughts where he ends up feeling suicidal himself. So when you say if you gave less importance to the thoughts, then hopefully that will give it. What I want to know is how easy it is. I mean, are there any steps that a person can take to reduce the importance of those intrusive thoughts that he has no control over?
Yeah, this is the pathology. This is what we nail. Our contract is not to remove the thought, not to control the thought. That is what the demand the patient puts. Now you change the whole concept that let the thought come. You don't give importance to the thought. If this thought is not yours, are you willfully bringing out the thought? That's what textbook says, that's what you say. If you are willfully means, then you remove willfully. Willfully means, then why do you feel guilty? See, previous steps I told 6 steps. One by one we explained to them. Very difficult to get across. But once you prepare the patient and move, I think it can be possible. So slowly it goes into his mind. The only thing he can do is not to give importance. Don't try to control the thought. Don't try to overcome the thought. That's what I told. You learn to fail after some time. So you fail miserably. So that part you separate, I think the cognition becomes much easier. So this has to be explained very clearly. Then he says that this is an ordinary thought. Everybody has this thought. Why you alone suffer? Because you have started giving importance. I didn't go into all the psychoanalysis, all those things, how you started doing all those things. Just what is present, we talk. And remove that connection between the thought and his effort. Then the anxiety drastically reduces.
Başka soru ve katkısı olan varsa onlardan da alalım. Yoksa ben 5 dakika kahve molasından çalmak bahsine kendi düşüncelerimi de aktarmak istiyorum. Yine Dr. Tirun'un yöntemiyle alakalı olarak Mazhar Osman'ın da aslında obsesif kompulsif spektrum bozukluklarının içinde çok iyi de tanımladığı şu saç patolojik kumar oynama, trikotillomani gibi rahatsızlıkların hepsini bir refleksif perspektiften ele aldığı ve oradaki hastalıklarda da söz gelimi trikotillomanide de bu konsekutif satisfaction olayı hani çok o yolduktan sonraki yahut da bir intermittent explosive disorder'da hemen onun ardından gelen o tatmin duygusuna da çok benzerliğini göstermesi bakımından da bu model çok mantıklı bir yerde duruyor gibi. Arka planında bu refleks arkının işleyişi zaten biyolojik bir süreç gibi. Mazhar Osman'ın da kendi tanımlarında şöyle geçiyordu. Hani refleks engel olabileceğiniz bir süreç değil. Herhangi bir bizim patella refleksini almamız için dokunduğunuzda nasıl refleks alıyorsanız ancak buna zihinsel ve düşünce kontrolü ilgili bu refleksi oluşturmaya gerekli kas gruplarını kişi kendisi kasında bu refleksi elde etmiyorsunuz da. Dolayısıyla böyle bir fasit daire de var. Acaba siz düşünceyi başlattınız ondan sonra bunlar obsesyonları mı geliştirdi yoksa obsesyonlar kendi içinde işleyen birer sistem midir? İki tane ayrı sistem gibi ele alabilmenizi de sağlayacak bir bakış açısı. Dolayısıyla hiçbirbirinden farkı da yok aslında. Hem bu psikososyal müdahale olarak tanımladığınız özgün terapi yöntemi hem biyolojik müdahaleler aslında aynı sisteme müdahale ediyor. Aynen söylediğiniz gibi nihayetinde beynimizde bedenimizin bir parçası. Çok çok teşekkür ediyorum. Ben hazır oturumda bulundukları için kongre başkanı ve kongre eş başkanlarından katılım için ödüllerini de sizlere vermek istiyorum. Katılım belgelerinizde. Mesut Hocam, Doktor Tirun'un ödülünü vermek üzere lütfen.